Good morning, everybody. Thanks for the organizers for sandwiching me between two Ranawats. Flexion contracture is quite often we see in India, but fortunately our Western colleagues don't see much. And more than normal, the people come with varus and flexion contractures into our clinics. The FFD need decreases the patient's ability to walk, and 50% increase in quadriceps work in the presence of bilateral contractures of 30 degrees. So it's a very important clinical outcome. And what are the flexion deformity? The posterior capsule, PCL, muscles crossing the knee joint posteriorly, all of them contribute to the flexion deformity. If you go for the grading, grade 1 is less than 15 degrees, grade 2 15 to 30, grade 3 more than 30 degrees. I'm sure you will all agree, many of our patients come in grade 2 and grade 3. In osteoarthritis, only the posterior capsular structures are tight, but in inflammatory arthritis, the bone loss is also there. And one thing is you should keep in mind, flexion instability may result if only excess bone is cut. So always resist the temptation of cutting more bone to get the flexion contracture corrected. So always try to correct it with soft tissue before cutting more bone. Otherwise you will end up like this. So when you can correct, there are 3 stages: preoperative, peroperative and postoperative. Preoperative, there is a role for manipulation and serial casting. Some of the people do not agree with that. Amenable only for inflammatory arthritis without osteophytes. Best suited for JRA with bilateral hip and knee involvement. Do the hips first, keep the epidural, and daily manipulations will help you. And beware of the fractures. I have done 2 fractures in my practice. Peroperative, the regular exposure and measured resection of the bone. Removal of osteophytes is a very, very important point from the back of the femur and tibia, and balance the gap. And tibial slope is very important. You got to at least minimum 5 degrees of slope, and PCL sacrificing is more important. Seldom you can correct them with the cruciate retaining, but occasionally you can keep the cruciate retaining as well. This is a simple case example which I have done last fortnight. 85-year-old doctor, and you can see the flexion contracture almost 60 to 70 degrees both sides. And osteophyte removal, the curved osteotome or bresto should be used, and you should concentrate underneath the MCL. This is the way to do the osteophyte. You got to put both hands and do it so that it will not have many thirst. If you want to kill somebody, you kill somebody like that with a knife, and that should not be used in the knee joint. And posterior soft release, you can see that you should release the soft tissue, lower femur right up to there. You can see that much of the forceps has gone back into the posterior part of the femur. That much release you can do without any consent for the vessels. So you got to really go and recreate the recess there on the posterior release. Gastrocnemius release, again plus or minus, but sometimes you need it to do that. And posterior capsulotomy, Dr. Ranawat has explained this in detail in one of his papers. You can do either in extension or flexion with the laminar spreaders under vision, either by diathermy or by knife. And even after doing all this, if you are still left with flexion contracture, you go and revisit the distal femur. 2 millimeters extra distal cut should be all right, and maximum up to 30 millimeters is permissible. This is the patient. You can see the flexion contracture on the table, and that is the post-op. And that is the post-op X-rays. And post-operative 2 or 3 points. No pillow under the knee. Generally, the patients feel comfortable to have a pillow under the knee, but that will aggravate the flexion contractures. We should resist that. Pillow under the heel is important. Knee immobilizer in night. Do not overuse the CPM. So, in synopsis, grade 1 deformity, simple debridement of osteophytes, strip posterior capsule, release PCL if needed. Grade 2 and 3 deformity, debride, strip, excise the PCL, resect the distal femur 2 millimeters plus or minus, release the gastrocnemius, and posterior capsulotomy is almost needed in every case. Acceptable corrections, again a thing of controversy. Some people do not accept residual contracture at all, but in my practice, I don't think there is any problem. In OA, full correction without residual deformity, and in RA, full correction is not aimed. Even in OA, if 10 degrees residual deformity is present, all of them will correct in due course. Anatomical repair might lead to quadriceps lag. Advanced medial capsule distally onto the lateral capsule like double breasting in extreme flexion contractures. Patella baha is another item to be considered. You should resist additional distal femoral resection, use other measures, lower the joint line by cutting more tibia, oversized femoral component in AP dimension to address this problem. Beware the nerve and vascular injury, poor wound healing, recurrent deformity, ligament instability, and subluxation of the knee. These are important points in dealing with the flexion contracture, but every orthopedic surgeon who wants to practice in India should know how to address the flexion deformities of the knee. There are a couple of examples here. Again, you can see this one, and that is a post-op correction, and another young lady, rheumatoid knee, and that is a post-operative straight corrections. So, my algorithm is first osteoporosis removal, then posterior capsular release, PCL sacrifice, gastrocnemius release if needed, revisit the distal femur if needed, posterior capsulotomy almost all the time, constrained implant when indicated, emphasize post-op rehabilitation. And be careful, whenever you got the deformity, you should not be distracted, you got to focus, otherwise you will end up in disaster. Thank you.